I don't care what anyone says, it hurts a lot. And if you can't elevate your feet, it hurts even more. It's incredibly inconvenient. Even if you've got a procedure you can weight bear with, it is difficult to get around. You can't do your normal stuff. If you've got a sore hand, you put it in the sling and away you go. Slow to recover. It takes forever to get better and forever for the swelling to go down. There are lots of complications, the main ones being wound issues. I mean, the foot is in a very ordinary environment. It's hot and sweaty and close to the ground. It's got all the full weight bearing. So, I do have my fair share of wound issues, wound breakdown, infection. It's not uncommon for a wound to gape a little bit at the bottom, and then of course it just leaks fluid out of it all day, and the patient has to change their dressings and all that. There are as many nerves to the foot as there are hands, and so it's very easy not even to see a nerve. All you have to do is move all the soft tissues out of the way to get to the bone. That nerve gets stretched, and bingo, it doesn't work for a while. Now, normally it recovers over 6 weeks, but people do notice it. They'll say, "Oh, my toes numb," or "This is numb," and that sort of. So the worst thing is if you hit a nerve and they get a sensitive area. That's the worst possible thing. People can cope with numbness and altered sensation, but when you get a hypersensitive area in a foot, whenever they put a shoe on it, it pings it. That's a really big problem. Swelling is not a complication, it is universal, and it's purely to do with gravity. When you stand up, you've got 1.5 meters of fluid from your heart to your foot, all in one column of fluid. The hydrostatic pressures just are going to cause swelling, and obviously the older patients, especially if they've had varicose veins, my ankle's swelling this summer anyway. Well, you know that they're going to swell like crazy. So you have to warn patients, and you have to expect that, 3 months down the track, the pain's all gone, the patient wants to get going, I can't fit into a shoe. And unfortunately, I don't have the answer for that. I routinely prescribe compression stockings, and I was very surprised when I came up here that no one else does. And it's not that hot up here. I've worked in Cairns where it's hot, but it isn't that hot up here that you can't wear a compression stocking. And they're just fabulous to help control the swelling. Expectations are often unrealistic. Too many people have watched DR and Grey's Anatomy and things like that, and they expect to be able to be the bionic man after their surgery. So again, it's very important at the outset that for me that I gauge what the patient's expectations are and make sure that the surgery matches. And likewise for you, you've got to tell the patient you can have this surgery done, but it's not going to make you suddenly 20 years of age again. And I don't ever operate for cosmesis, because no one is ever happy. I've never met any person who says, "Oh my God, I love my feet, they look so beautiful." It can be extremely rewarding, as I said, if you can get a patient who can hardly walk to walk around the block. Alignment and movement are imperatives, and I think if a foot looks like a foot and it moves, then it usually functions like a foot. Obviously not every case. So I'm very big on trying to get a functional alignment to the foot. I use local anaesthetic a lot. Every patient who has foot surgery gets a block from me, so even if you have a general anaesthetic, I'll put a block in, and usually it lasts 6 to 8 hours, can be longer. You just have to warn the patient that when the block wears up, it goes from 0 to 100 in about 1.5 hours. So once you feel sensation, get your painkillers on. It's hard to cover the Achilles in the lateral heel. I'm very big on preemptive analgesia. Once you feel sensation coming back, start your painkillers so you're ahead of the game. Don't try and play catch-up football. Likewise, if the block's there when you go to sleep, take your painkillers before you go to sleep. I use these pain pumps. I'll put them in either in the wound, or more likely I use an ultrasound machine to put them in near the posterior tibial nerve, and saphenous nerve, other nerves. And they start 6 hours after surgery, and they run at 4 mils an hour for 50 hours. So if you see some of my patients immediately after surgery, they'll go home with these things, and they just pull them out when it runs out and put it all in the bin. They work by themselves. The only reason to take them out early is if they leak or get blocked. And so sometimes they work brilliantly, other times not so great. But it's better than nothing. Elevation is the key. And if I can say anything at all, elevation, elevation, elevation. Because it decreases the edema, decreases the pain, increases the wound healing. And patients come back and say, oh, whenever I put it down, it throbs, and when I put it up, it feels better. And I say, well, I told you that. And I say, yeah, but I didn't really believe it. So, if the patient contacts me and they're having a lot of pain and swelling, I'm saying, have you elevated the foot all the time? Oh, no, but get it up. That's the first thing. Strike through on the wound is where you get blood draining through onto the dressing will show through. That's pretty common, especially with the pain parts. And also, often in claw toe surgery especially, the circulation doesn't restore to normal for a long time. Usually it's venous congestion, so the toe will have a purpley dusty look for a long time. If you touch them, they've got good capillary return, so you know their arterial supply is okay, but they are dusky colour, and I get a lot of phone calls from worried pods and GPs saying, oh, the foot looks dusky, and these days, fortunately with photos, I can get one saying it looks fine, just elevate it and it'll come good. For some reason, pain in surgery is worse at night, especially if they're for a long period. So I always advise patients, if you've got the strong painkillers, if you don't like taking them, at least take them at night so you can have a sleep. Because again, patients who don't sleep go crazy, and then they start, getting angry and things like that. Foot surgery is not high risk for DVT. Obviously, if you've got a patient who's high risk, such as previous DVT, family history, protein C, protein S deficiency, they need thromboprophylaxis. But immobilisation does not mean a time in plaster. Immobilisation is a little old lady with pneumonia in bed who can't get out. Right? So just because you put a foot in plaster for 6 weeks non-weight bearing does not place them at an increased risk of DVT. Achilles tendon ruptures are not at a massive increased risk of DVT, but I can assure you, if you anticoagulate someone and operate on an Achilles tendon, they are at massive risk of wound breakdown, which is a disaster. So I don't anticoagulate my patients unless there are other reasons for it. If they really want something, I'll get them to take half an aspirin. Okay, so if a patient, is worried that they're going to get a clot because they've had their bunions or their ankle fusion or something like that, big studies have shown that they're not at high risk. So these are the common conditions, and again, bunions is down the list a bit up on the Sunshine Coast from what I've seen. So bunions, claw toes, first MTPIA, midfoot arthritis seems to be very common up here. Hindfoot arthritis, likewise common. Most ankle OA is post-traumatic, subtalar similarly. Tib post tendon failure, and again, it's not recognised as well as it should be. It's not taught well in medical school, and really I only found out about it in orthopaedic training. Tib post failure, which leads to adult flat foot, is a very, very common problem. Often it can be treated by you guys with orthotics and anti-inflammatory modalities and that sort of thing, and people can get by, but when it becomes too bad, it needs surgery, or else it's going to progress to degenerative changes. Achilles tendon pathology likewise is very common, both insertional and non-insertional tendinosis. Again, the non-insertional, it's routinely treated conservatively, and that's an eccentric heel lowering program, but the insertional often comes to, more often than not, comes to surgery if it's bad enough. So I'll just talk about some of these conditions. Hallux valgus, I see it in sort of two populations. The first one is, an 18-year-old girl who comes in with bunions that she's had all her life. That's not due to her or bad shoes, it's her parents. So she's got a congenital hallux valgus, and when you operate on these girls, and I say girls because most of them are 2/3 or so, you have to warn them that because their body wants them to have a hallux valgus, even though I operate, it'll try and grow your toe again to have a hallux valgus. Plus, they'll go on and wear shoes their whole life, so they'll almost certainly come to a second operation in their 50s or so. The second group is those that started with normal feet, but for one reason or another have developed hallux valgus over time. And so that's, your 40-plus patient who says that, I wore high heels in my 20s and all that sort of stuff. It's not necessarily related to high heels. Hallux valgus is common in shoe-wearing communities. Doesn't matter what sort of shoes. Communities that don't wear many shoes don't get as much hallux valgus, but still get some. But you don't necessarily have to be wearing high heels to get a bunion. Don't forget that bunions are not just a bony problem, they're soft tissues. So when we operate, we've got to deal with the bone and the soft tissues. In my hands, they'll spend 4 to 6 weeks in one of the flat, rigid, soft-soled shoes, mainly because they have trouble fitting into another shoe because of the swelling and pain. But you know, if you've got a patient who's 3 weeks on the track and you want to put them into a sandal, because these shoes aren't very safe for patients, and if you want to put them in a sandal, then that's fine. I'm happy with that. And most patients will automatically weight bear on their own heel anyway. Remove that in bed and to sleep and shower. And if you're seeing any of my patients with hallux valgus post-op, feel free to mobilise them. Movement is everything. And if you end up with a stiff big toe, you may as well not have had the surgery. So I'm very happy for you guys to do mobilisation if the toe is going stiff. Or if you feel that it's deviating a bit post-op, don't be afraid of putting a splint on, especially at night, or even taping them and that sort of thing. Obviously, if you want to contact me first, that's fine. I'm happy to speak to you. But if you've got one of my patients who's got bunions or corner toes that are not going as well as we'd like, feel free to do some intervention as long as the wound is healing. And you would have all seen hallux valgus cases. In terms of X-rays, the main thing we look at with X-rays are the angles, and I'll go through them in a bit. But if you have a look at the important things, is the angle between the first and second metatarsal is not too great. The angle between those bones, the phalanx and the metatarsal, not too great. The sesamoids basically sit underneath the metatarsal head. And they're the main things we look at. The other one, which is called the distal metatarsal articulation angle, is the angle this joint makes with the longitudinal axis with the metatarsal. And in juvenile hallux valgus, what we find is that this joint will be poking that way. Even though these two bones are close together, the joint points that way. And so even if you do regular bunion operation, which is to move that bone across, unless you can rotate the joint around, you won't fix that problem. And that's what I mean by congenital problem. The bone has a different shape than the majority of patients. So these are the angles, and to be quite honest, I would rarely measure them. You just get a sort of vague idea. But that's the intermetatarsal angle there between the first and second, the hallux valgus angle, and there are lots of numbers you can remember to try, what's normal and what's not. Sesamoid uncovering, you can see here that the sesamoid's partially uncovered, and the distal metatarsal angle is this angle between this line joint from the joint surfaces with the perpendicular to that with the metatarsal shaft. So that's, and a lot of those are mainly talked about in presentations and research and things like that. You don't need to measure angles to know that that's a bunion. The question is then, how do we fix it? And there are 152 different operations to fix bunions, so clearly not all are correct. But I just thought I'd mention some of the common ones. One of the common ones is what's called a basal procedure and a first tarsal-metatarsal fusion or a lapidus. And basically you cut the first tarsal-metatarsal out, and Medartis makes some really nice strong plates that we can use to hold the bones in position, and that allows us to weight bear the patient. And it brings that metatarsal back in line so that the intermetatarsal angle is closed. If I do that, I'm always doing something distally as well. Usually it's a soft tissue release, and it may be what's called an Aiken osteotomy, which is a closing wedge of the phalanx. The scarf osteotomy was introduced to Australia in 2000 by a fellow by the name of Louis Baruch, who was a very excitable French fellow who came over. He charmed us all with his wit, and he's hosted many Australians in his vineyard in Burgundy. And he would say, all his works, and the scarf osteotomy, we do 1,000s, and it's cut it like this, and magnifique and perfect, and they all work. Well, they don't all quite work, but it's a good operation. So basically what you're doing is you're cutting the metatarsal and shifting it across closer to the second metatarsal. I do it for patients who are really wild IM angles. Like that, I'll do a basal procedure because it's more powerful. If it's a lesser IM angle, I don't want to fuse that first TMT joint, so I'll do a scarf osteotomy. And in Australia, it's basically the go-to for most surgeons is the scarf osteotomy. It's replaced the chevron. It's more powerful, it's more stable, you can shorten or lengthen, you hold it with 2 compression screws, and every company has their own scarf osteotomy set. And this is just to outline how you do the osteotomy. That's looking for the slide. You basically shift the component with the head across, put a couple of screws in, and that's what it looks like in the end. And you can see here what I've done is I've also rotated, so I'm correcting a bit of distal articulation. I haven't just shifted straight across, I've rotated a little bit to straighten out the joint. And again, a very stable operation. The next one is basically the add-on. This is if you want fries with the order. If you're not quite happy with your lapidus or your scarf, you just do a little closing wedge. So you cut a wedge out of the phalanx, close it up, fix it with a little staple like that. And that just is the cherry on top that straightens the toe out. And again, it's very easy to do, and it really gets you, it makes a moderately good-looking foot a beautiful foot. And that's what you want in the end, a straight foot that lines up. And if you do that, most patients are pretty happy. You've then got to worry, obviously to make sure that they get their movement back. And I routinely use physiopodiatry to get mobilisation of the toe early on. Once the wounds are healed in 2 weeks, you start moving. They usually don't need splinting, but they certainly need encouragement to move it. So this is just my post-op regime. Normally they'll be 4 to 6 weeks in the post-op shoot, mostly because they're swollen and can't fit into anything else. But I'm happy to substitute sandal for shoe. Nurses will need 6 to 8 weeks off for a bunion, but a secretary who has their left foot done might be back at work in 3. If you're a brickies labourer, you'll need 8 to 10 weeks off. So it depends on what you do is how much time you need off. Claw toes are extremely common. I think it's due to a muscle imbalance that basically causes intrinsic failure, and you then get this long flexors and extensors causing this indicated joint. And if it's long standing, the PIP joint becomes fixed. Patients present with 3 different problems with claw toes. Pressure under the metatarsal head, because if you elevate the phalanx, you depress the metatarsal head and they get walking on stones. PIP joint, getting corns over the top of them for rubbing on their shoes, or corns under the tips because they're rubbing like that. I think because you've got the deformities at 3 different levels, you've got to do the whole thing. I know some people just cut the tendons, but I'll do a tendon release both flexor and extensor. I also release the MTP joint because otherwise if you just straighten it out, it sticks up. So you've got to get the toe down, and I fuse the PIP joint. I use an absorbable pin so that you don't have a wire sticking out the end of the toe. And that's been a bit of a game changer as well, especially if you're just doing an isolated second claw toe. It means they're back at work in 2 weeks. Whereas if you've got a wire sticking out the end of the toe with a germ ball on it, that doesn't get pulled out for 6 weeks, and it's a problem. So post-op, if you're just doing claw toes, it still requires a lot of elevation and time off because these wounds are very highly prone to fall apart. You have to warn the patient that they may have altered sensation for a very long time because the nerves of the little toes are tiny, and even when you don't see them, just the swelling and the manipulation can cause them to be permanently altered. And patients will say it's okay, it just feels different than the other toes. The other one is what's called a floating toe. So their toes sitting like this, you correct it, and it sits just a little bit off the ground. Now it has no functional disability, but you've got to warn patients about it because otherwise they'll say, oh, my toe doesn't touch the ground. They're used to it heavily rubbing on the ground, suddenly it doesn't touch. So you just say, that's just the way, that's it straight now. And when you walk, as soon as you go forward, of course it's going to hit the ground. Claw toe surgery, they get over much more rapidly, and you would see these every day of the week on certain of them. This is the absorbable pin that I use, the spin pin. So basically, you put it in like a normal K-wire, but it's got a groove here, and you spin it and it breaks off, so it's only retained within that part of the bone. HALLUX rigidus, another common complaint. Now, do you all know what I mean by colectomy? No. Colectomy stands for excision of lips in ancient Greek. So if you've got dorsal osteophytes on the metatarsal head and the phalanx, when you dorsiflex, they kiss each other and impinge. So in early OA, patients may only complain of pain due to rubbing on shoes or when they go into toe off. But then once they stop walking, there's no arthritic ache. So the majority of the joints in reasonably good shape. They might have some lost dorsal condyle cartilage, but their main problem are the bony osteophytes. And a colectomy involves excision of basically not just the osteophytes, but I cut out the top 20% of the joint. And it means that they suddenly get no dorsal impingement and no pain. And it's a wonderful operation in early OA, but the problem comes in that they're too bad. If they've got arthritic ache, then a colectomy is not going to solve the problem. It's a very rapid recovery. Usually you're back in shoes in 2 weeks, back playing sport in 6 to 8 weeks. So it's a really good operation for early OA, but you've got to catch the patient. And it seems to slow down the progression of arthritis and put off the need for anything further for some years. You know, the number of patients I did a colectomy on saying, look, you'll be back one day. They come back 6 or 7 years later and they're having their other foot done and say, how's the one I did? And I say, fantastic, never look back. So it seems to slow down the progression of the osteoarthritis. And it's a really rapid recovery. Once the patient gets arthritic ache in the joint, you have to do something with the joint. And there's a multitude of operations, but the two that I do, fusion, which is the so-called gold standard, and it's a truly terrific operation. But when I first started, I had a young guy who had post-traumatic OA. I did a fusion. He came back a year later and I said, how you going? He goes, oh yeah, good doc, I'm pretty good. I don't have pain, I go to work, but I can't run because you can't dorsiflex. And I thought there's got to be something better. So I started doing joint replacements. And I've done over 250 first and TP replacements, certainly more than anyone in Australia, and perhaps more than anyone in the world. They're not all great, but my best joint replacements are far happier than my best fusions because they're pain-free and they have movement. Now, it's not an operation for someone who's, going to play rugby, but I remember the receptionist at the physio down the road came and said, I'm a marathon runner, I don't want a fusion. I realise I won't run marathons, but I want a replacement. So I did her replacement and she got back up to 14 Ks, but couldn't run any more than that. I had another woman who was about 5'2", came in, dressed in power dress, and she was a commercial real estate agent, said, I'm 5'2", I have to dress like this every day, which means high heels. I can't have a fusion, I'm going to have a replacement. So it's something that it's a big discussion with the patient. They do extremely well and they retain movement. But, it's a big discussion about the fusion versus replacement. Yes?
I wanted to know though, when you fuse, doesn't that affect biomechanics all the way up?
Not as much as you think. What patients do, and we've seen this with our treadmill and gait analysis, they just shorten their stride. So instead, no, both. Yeah. So if someone comes in with a fusion on one side, I'll never do a replacement on the other because there's no advantage. So all you do is instead of a toe, instead of taking a big stride, you do, yeah.
But that will affect your hip flexors.
Nope. You got to remember, we're not talking Olympic athletes here. The average first MTP OA patient, as you know, a middle-aged bloke.
Well, I imagine that if you're doing it in somebody whose joint is stiff.
Absolutely. That's the other thing, is that they've had years of stiffness anyway. Leighton Hewitt played his last few years of tennis, professional tennis. He had a colectomy, which didn't work. He then had a fusion. And he played for another year or two with a fusion. So, the old you can't run with a fusion isn't quite right, especially now with the modern runner with a good 4-foot rocker. And again, if you're into running and gait analysis, mid-foot running, which has come about through the whole barefoot thing, is a short stance, no big steps, short, you're landing mid-foot flat, and so you can run like that with a higher cadence, shorter stance phase, and do quite well. You can't sprint. Yeah.
One question: how long would you say that a joint replacement would last?
That's
This is a $1 million question.
It is. Well, I started doing them in 2000. I left in 2020, and I still had, because I would see my patients every year or two, just because it was a new procedure and I wanted to find out what was going on. Now, what usually happens is the prostheses aren't very good. They're not like knees and hips, and they subside in the bone and the phalanx. So over years, I'd watch these patients come in because I'd do an X-ray or a CT on them, and this component would sink further and further into the bone until eventually the bone was touching the head of the metatarsal, and they may as well not have had a phalangeal component at all. And they were quite happy, because it happened so slowly, and they would still, they'd lose movement over time, but they wouldn't get painful. So yes, the prosthesis has failed, and on an X-ray looks very ordinary, but the patient's happy. If you said, I'm going to do an operation, I'd say, forget it. So how long do they last? There tends to be a number that fail in the first year or two, and if they get beyond 2 years, they tend to go beyond 10.
And then they can't get a second one done, can they?
Well, there's no such thing as revision prosthesis.
Yeah.
I have revised one component in some, but generally by then, most people, it's easier just to fuse them. The big problem with fusing them after a joint replacement is that they're short, and they end up shorter. But if you've had chronic pain because the replacements fail, you don't care about the shortening, you just want to get it pain-free.
Is the prosthesis bulky? Like, does it add width to the foot?
No, because it's totally within the bone. Well, sorry, there's 3 different prostheses out there. One of them has quite a bulky head. The other one is not bulky, but it's not anatomically shaped. And this is the problem, is that the prostheses suck. And I went over to Switzerland to talk to the designers of the Smith & Nephew one, and said, look, you need to shape it like this and this and this. And they said, you can do what you like, but just don't take my royalties. So nothing happened. So I'll show you, I've got an X-ray of a joint replacement. So there's one of the early joint replacements there. So you can see that the vast majority of it is in the bone. The beauty of that one is that there's the neck shaft angle, whereas and that one there is by a Texan company, but the Smith & Nephew one, which is made from the Swiss company, it doesn't take into account the angle between the metatarsal and the midfoot osteoarthritis is very common, but vast majority don't need surgery. Usually it's the first to 13 T joints you're fusing. You can't fuse the 4th and 5th, otherwise patients can't walk properly at all. It is a very long recovery. They really are 6 weeks on weight bearing plaster and then another 6 in the boot, and it takes 3 to 6 months to get over. So you've got to earn this operation, and that's a very old slide. I'd use one of the Medartis plates if I was fusing a TNT joint these days. They're so much stronger than just screws. So that's a very old X-ray. I need to change that. Ankle and subtalar arthritis. Again, most ankle arthritis is post-traumatic. So it can be in young people, nowhere near as common as knee and hip, but ankle arthritis has been shown in SF36 and other life schools to be as debilitating as hip arthritis. And again, fusion versus replacement. And I've done over 80 replacements, but hardly do any at all. And a lot of Australian foot and ankle surgeons don't do replacements anymore because they wear out. And when I first started doing them in 2000, I thought technology would come along, and by the time they start wearing out, they'll have new and new designs. It just hasn't. So you have to be, I will rarely do an ankle replacement in someone under the age of 60. Simply because I'll be in practice at least another 10 years, and I've got to look after them when it starts going wrong. Subtalar fusion is a fabulous operation. Most people who have subtalar arthritis, these are just a picture just to show you. That's the ankle replacement that I do, but there's a whole lot of different ones on the market. It's a whole talk in itself. Ankle fusion is a very good, reliable operation. It certainly does alter the biomechanics of the gait. There's no doubt about that. Patients have to learn to walk again. We often will suggest rock bottom shoes. And you can't run or do anything like that. But again, if you've got debilitating ankle osteoarthritis, you're just grateful not to have the pain anymore. But this will affect their gait in a very marked way. Although if you walk slowly, you often can't tell which side's fused. But once you start getting a bit of, even more than just a slight pace, it's very obvious which one, because they can't take a full step. Subtalar arthritis, again, this is a very good operation because in normal everyday walking on a flat surface, the subtalar joint doesn't come into play. It's got a little bit of dorsiflexion, but very little side-to-side movement. It's only on uneven ground that you really notice it. And so, for the vast majority of patients who've got an arthritic subtalar joint, it's already stiff, so they don't notice that they don't have movement, and they don't lose dorsiflexion. So that's a really good operation. Tib post failure, again, common and often missed. Presents insidiously over many years as an asymmetric flat feet, and I'll talk about that a little bit in the next talk. The operation I do is a transfer of FDL, a spring ligament plication, and what's called an arthroresis screw. An arthroresis screw is like a little round screw that goes into the sinus tarsi between the calcaneus and the talus, and it blocks hindfoot valgus. So it acts like an internal orthotic. Yeah.
How many would you see a year?
This,
Yeah.
in Melbourne I was seeing 50. We're operating on 50. Really common, really common. And they're the ones who need an operation. The vast majority of adult flat foot is tib post. But most of them don't progress. And especially because I've never seen anyone with tib post who's never had an orthotic. I say, look, my podiatrist gave me this orthotic, it's been really good for 5 years, but now I've just got too bad. And that's the common story. So that's the arthroresis screw, and that's where so it's not actually screwed into a bone, it's jammed into the sinus tarsi as a blocker. Achilles tendon rupture. If you want to see a 2-minute talk on how to diagnose Achilles tendon rupture, go to my YouTube channel, Sunshine Coast Orthopedics, and there's a little video. But you can see clearly just by looking at having the patient either kneel on the chair or lie on the bed, the ruptured side, they don't have the tension of the calf, so they go into dorsiflexion, and it's easy to see. You can see that clear on there. Whether to operate or not is a major contention in foot and ankle surgery. If I catch someone within 24, 48 hours or even up to 72 hours and they can be put into a kindness cast, then I'm very happy for not to be operated on. Usually if they're presenting in a week, you don't know when there's hematoma filling the gap, so I'll generally operate on them. I do an open procedure. I know there are percutaneous methods, but I'm so afraid of catching the sural nerve that I just do an open procedure. But I am scared of the wounds. I'm very aggressive by rehab, so 2 weeks and I won't bring a plaster, mainly to get the wounds healed, and then they go full weight bearing into a boot with a heel raise, come out of the boot for exercises to sleep and shower, and then at 6 weeks they come out of the boot altogether.
So you're saying if if you suspect that they may have an Achilles rupture, they need to be in a boot and sent straight to you, emergency.
Oh, well,
24 to 70.
Yeah, put it. Well, I put.
Is that what you mean?
Let's say if you fell down here and I said you've got Achilles tendon rupture, I would put you in a Aquinas cast like that for 3 weeks, then get you in a boot, and that's how I treat you.
Okay.
Yeah. They don't all need surgery,
Right.
and I've treated Olympic athletes like that. So the problem comes later on. If you see them down the track, you just don't know whether there's a hematoma between the twins of the tendon, and it's not going to heal properly. So they're all operate. So in summary, foot and ankle is a high risk surgery, wounds, nerves, chronic regional pain, low risk for DVT, very painful and very inconvenient, but can be very rewarding. So, hopefully we can form a relationship over the years, and you can help me with my problems, and I can help you with your problems. Yeah.
On chronic regional pain syndrome, you were saying before that being a high risk. If a patient has chronic regional pain syndrome from a previous foot surgery, is it worth getting a second opinion from someone like yourself, or is there anything that can be
The
done
problem
from your
comes-
perspective?
No, not really. The problem comes when you've got someone who's had chronic regional pain in the past and they present with a problem that needs an operation. And you've got to warn them that they are now at high risk of getting it again. Now, when I operate on people who are at high risk like that, I'll always use a regional drill. Sometimes we use clonidine. We'll be very, very big on seeing you guys and physios post-op. I'm very big on hydrotherapy, and I'm so grateful for the pools that we open here. But you just have to warn them that they are at high risk. I mean, foot surgery is probably no higher risk than anyone else for chronic regional pain, and it is still rare, fortunately. It's just that when it occurs, it's a disaster, if it's really bad. Most are mild and self-limiting and get better within 6 to 9 months. And, you know, the really bad ones, it's just terrible. Yep.
Do you see many loose frank injury yourself?
I'm sure that there are more that are out there that I don't see. Because my weight-bearing CT that's one of the newer methods of diagnosing the subtle loose franks. When I worked in Scoot, I did a trauma list every Tuesday, and so we, you know, I all got sick. I got lots of them there. The big controversy is the subtle loose frank in the athlete. You know, the patient who's not getting better, they're sore over this frank, but the X-rays are normal, MRIs inconclusive. So that's where my weight-bearing CTs come in. We're doing a protocol for non-weight-bearing both feet and weight-bearing both feet, so you can compare left and right, and you can compare weight-bearing to non-weight-bearing. You look at the different gaps and the volume of space between them. So
even if it's like if there's a weight-bearing X-ray and there's no significant difference, but it's clinically unstable and chronically having issues, is that something you would personally operate on?
I would do a weight-bearing CT if I, you know, in my gut said, look, you know, I don't want to miss it. Then, and it's interesting, I ask my colleagues, you know, what do you do? And they say, well, I explore it and have them open it up. If it's unstable, then I'll fix it. The problem is, in order to have a look after the glided ligaments, and of course you're making it unstable. So I'd rather operate on too many than miss them. But the weight-bearing CT has reassured me so many times in that, you know, because I'm sure there are too many operations done, certainly in Melbourne. But it's because you don't want to miss them. So that's where we're trying to find a really good way of diagnosing them.
And do you personally leave pins in, or do you take it out as a case?
I use plates. So I use bridging plates. Yeah, I don't put screws across the joint anymore because I figure the joint's already been upset enough the last thing is for me to plate a screw across it. So I use plates and they come out in 6 months.
Yeah.
Yeah, most people can't get back to proper sport while they're playing their foot's too stiff. But I leave them 6 months because I don't want late displacement. Yeah.
What about compartment syndrome?
In the foot or the calf?
In the calf.
In the calf. So we're not talking acute compartment, we're talking chronic exertional compartment syndrome. So essentially they've got to have the pressure studies and shown to be high. I do it through a double incision. I'll release deep posterior, anterior and perineal. So the anterior and perineal through the lateral incision, then the medial incision does the deep posterior compartment. Unless it's absolutely clear that it's only one compartment, and that's pretty unusual, I'll do both, just because I don't want to miss it. High risk for wound breakdown, they're usually muscular individuals, slow recovery, there's still a lot of stretching and things like that to be done, because most compartment syndromes don't need surgery. You know, they're either overuse injuries or they're tightness in response to deep frictional massage, biomechanical factors, things like that. But yeah, they've got to have pressure studies done. I must admit, I'm not sure who does pressure studies here on those. There are portable, you know, dynamometers you can use.
Okay, thanks.
Yeah.
Hi, do you do just normal, like minimally invasive, like flexor and extensor tenotomies?
Oh, absolutely. The flexor extensor tenotomies you do. There is a branch of orthopedic surgery called minimally invasive surgery, which came about less than a decade ago. So basically, it's operations that are normally done open and now done with special burrs through tiny cuts, bunions and things like that. Now, there's a very long learning curve. I am now using minimally invasive burrs, and modifying my techniques to use much reduced incisions. So I'm now, MIS is minimally invasive, I'm now calling mine modus, moderately invasive. Because I'm not going to go through the whole learning thing, 2-year learning period to learn how to do bunions and look weird on x-rays anyway.
Yeah.
So I've definitely changed my technique in the last year and a half, and I'm now using minimally invasive techniques to reduce the size of my wounds, because wound complications are the biggest thing I feel. And I've been very successful and happy with what I've been doing, but I'm not going to go the full hog.
No. But what about just like, you know, in the rooms and you just...
No, I do nothing in the room.
Nothing?
I'm not set up for it.
Oh.
Yeah, I'm just not set up. It's not worth my while doing something in the rooms, getting complications very soon.
Yeah.
You know, I don't have the instruments and all that sort of stuff.
Have you had many complications with plantar incisions?
It's funny you ask. There's a patient in here who's had a plantar incision. I've always been scared of plantar incisions for no good reason. I've never had a major complication. I've had a couple where there's been minor infections and minor stitch abscesses and wound breakdown, and every time I do one I think, gosh, I should be doing more of them, but then I don't. So, you know, my mortise neuromas I do dorsally, medial sesamoid I do from the medial side, lateral sesamoids, maybe a few I'll do from the inferior aspect, from the plantar aspect. So I shouldn't be as scared as I am. Now I do have one more talk if people don't mind. What's that, how are we going for time? And this one is more cases in orthopedics, so hopefully it's what you thought you'd come in here. Right, so I will be interested in some feedback on you on some of these conditions in terms of what you think of them, what you call them, and how you treat them. So this is how I set up to do an ankle arthroscopy. I use non-invasive traction. Some people use a here, a pin in the heel. And basically it's just to distract the joint, so when you're putting the scope in, you're not going to scuff it up. And so you can see we use a 2.9 millimeter arthroscope. And this is the usual picture. So when I do my scopes, tibial plafons here, posteriors at the back, talar, dome there. So we're looking at the different structures. That's looking laterally at the distal tibiofibular joint. The probe there is 5 millimeters, just to give you an idea of the size of things. So this is what an osteochondral lesion looks like. Obvious on the CT scan, not so obvious on the X-ray, but when you get in, you can see it's a big flap of cartilage, and that's, you know, a good 1.5 to 2 centimeters, which is a really big piece of cartilage. And you can see how it's just delaminating off the bone there, and you can't stick that back on. I've done it once in my life with a 16-year-old kid, but other than that, you just can't stick back. So what you've got to, the way I tell patients is these flaps act like a hangnail. When you catch them, they hurt. If you trim them so that they don't have a flap, they don't hurt. The body tolerates a hole more than a flap. But the problem is you've then got exposed bone, and cartilage is there to keep the stress off the bone. And when bone gets stressed, it releases chemicals into the joint, and these produce pain, swelling, and all that sort of stuff. So what we try and do, and that's at the end picture, that's an arthroscopic wall, and it basically is like an ice pick. We nickname it Sharon Stone for all those who remember the movie. So what you do is you get that and you penetrate the subchondral plate about 3 millimeters. The idea is that the stem cells underneath come up and they'll lay a fibrocartilaginous layer that protects the bone from stress. It does not ever regenerate articular cartilage, and even when we were able to do the procedure where we take that articular cartilage, send it off to the laboratory, they grow it up and then we glue it back down. Even that doesn't grow true articular cartilage. You're born with a certain amount and that is it. So articular cartilage is gone. Microfracture, which is what that procedure is called, is about 86% successful in most lesions. By and large, if you have got a 1 by 1 centimetre lesion or less, you do very well with debridement. If it's more than 1 by 1 centimetre, you're more likely to have problems. Achilles tendon rupture again, diagnosis just by looking, but the squeeze test is the way. Does everyone know how to do a squeeze test or a Thompson's test on Achilles? If not, you need to find out. You do not ever need an ultrasound to diagnose Achilles tendon rupture. In more cases than not, it will be confusing because the patient will come back saying partial rupture, some intact, and they're looking at plantaris or they've missed it or something. Ultrasound is not required for diagnosing, and I've seen more delayed diagnosis because of misread ultrasounds and look at the patient and then do the Thompson test, the squeeze test. Okay? If it's positive, they've got a rupture. I've seen maybe 2 partial ruptures in 20 years of practice. So again, partial rupture is a rare beast. This is what tendon degeneration looks like. Normally tendons are white and smooth like this, and that tendon there is degenerate. Often they look like they've got crab meat and they don't shine and they're yellow and they won't have the homogeneous appearance. So that's what a degenerative tendon looks like. I'm showing these only because you guys hear about it and get all that, but you probably never ever see them. So now whenever someone says there's a degenerative tendon or a normal tendon, in your mind's eye you can imagine this. That's another tendon, that's a perineal tendon, and this is what happens with perineal tendons as they flick around the lateral malleolus, and then we just basically suture them up as best we can. They usually get longitudinal tears and this frame.
Did you black that one?
Poo one, nip one. Unfortunately, I have to do all the sewing at home. My wife doesn't sew any buttons anymore. So this is the test I do for tib post failure. So it's basically in a normal heel when you ask them to do a heel raise, because of the tibialis posterior and also the medial pull of the Achilles. And if you've got a mobile subtalar joint, you can see on the other side the heel moves into varus. Now, what would you call that motion from that position to that position? I call it heel varus. Resupination. Any other? Inversions. So you can see we've got four different names. Four different names for the same, just that very simple movement there. And this is the problem, is that we don't all talk the same language. So when I would describe that in a letter, I would say that the heel moves inwards when you rise onto the toes. And that way everybody knows what I'm talking about. Okay? Because in my mind, supination is a vastly different thing. Inversion is different because it's a compound movement involving the midfoot and forefoot as well. Okay? So I call that calcaneal varus. Right? And that's why I encourage you. I know it's a lot more to type and write, but say it in a full sentence so everybody is clear exactly what you're talking about, because otherwise there's a lot of misunderstandings. So in acquired flat-footed tib post failure, you've got failure of the heel to move into varus. So you can see on the left, even though it comes to neutral, it doesn't go to varus compared to the other side. This is one of the ways I do my test for isolated testing. It's usually this way. I'll put the foot, and I'll actually position the foot with the patient sitting, their leg resting on my leg, and I'll position them into a position, I call it inversion of the foot. And then I'll ask them to resist me trying to push the foot outwards. And even little old ladies can resist with tib post. It's a very, very strong tendon. And then you test the other side. Usually you test the good side first, and then compare it to the affected side. This is another way of doing it. Just ask the patient to lift their first metatarsal, big toe, up towards the roof, like they're sitting cross-legged. Not everyone can sit cross-legged like that. So the thing to be very aware of when you're doing any of these tests for tib post, tib ant can mimic it. So you've got to make sure when they move their foot, they move it into plantar flexion as well. Because if they dorsiflex or even go slightly, straight across, often tib ant can be the power. You can see it, prominence. Spot diagnosis. What is this? No prizes, unfortunately, but anyone? Bueller? Anyone? What was that? Who said that? Who said gout? Say it louder. Be confident. Yes, that's gout. So that's a gouty tophus. And the X-ray gives it away with that sort of funny calcific sort of soft tissue thing. Ganglions don't show up on X-rays. And for those who want to see what gout looks like, it's horrible. It looks like the dried up toothpaste on the end of that sort of thing. Gout is a terrible disease. Fortunately, with the medical treatment being better, we don't see it like this much anymore. But it disrespects all planes and it invades the tissue and can cause degenerative joints. And there's a very high rate of wound breakdown when you take these gouty tophus out. But that's what gout looks like. Dried up toothpaste. All right, now I know you're all going to say, what's that? Yeah, and what's that due to? Yeah, and how much pain does that cause, a heel spur? 0, correct. I'm glad to hear it. The heel spur plays no role in the pain in plantar fasciitis. In fact, on MRI, you can see the plantar fascia comes from here. When we do surgery, we never touch the heel spur. Oh, I certainly don't. Patients who get better with plantar fasciitis have got that heel spur there forever. Okay, so the term heel spur syndrome is a terrible one. Don't ever call it that. And I'm glad to see you all said that it doesn't play a role in the pain. What is that? Yes, calcification. Where is it? In the Achilles tendon. So this is chronic insertional calcific Achilles tendinosis. And do you know of an association with that? An increased size of HALLUX. And the thought is that because you've got a bit of HALLUX, when you dorsiflex, it hits the Achilles tendon here and interrupts the blood supply, because the blood supply to the Achilles comes in here and here. This needs an operation if it's symptomatic. It will never get better by itself, and it usually has a big lump on the back of it. So people have trouble fitting shoes. It's a degenerative process that occurs over many years. It can be asymptomatic for a long time, and then for some reason becomes symptomatic. And it's presumably due to failure of healing at the Achilles insertion, producing dystrophic calcification rather than parative tissues. The ultrasound will report in the early stages, before you can see something on X-ray, that it's either got partial tears or degeneration of the insertion. And usually at that stage you'll treat it conservatively, but by the time you get someone like that who's come to see me, they need an operation. And so what I do is you have to go and peel the Achilles off, because that's truly within the Achilles tendon, that spur. I then will cut the whole back half of the heel off, because I want to get rid of that in case it's causing problems. And then I reattach the Achilles tendon with a special corkscrew anchor, and then the 2 weeks in plaster, then straight into a boot, and away you go. It's a long recovery, 6 months, but it's worthwhile. And this can occur in very active people. I've had 2 Masters world champions have this problem while they're still competing, and 18 months afterwards they both got back to running. But it took that long. So that's chronic insertional Achilles tendinosis. Now, just a word about fractures. It looks a bad enough fracture, but it's a tibial fracture and all that. With any fracture, remember the soft tissues. Even a little ankle fracture, you don't know what the soft tissues have done, where the foot's been before it fractured. It might have been, these days with high-speed video, you can see these injuries where the foot goes 90 degrees the wrong way, then springs back. You have a look, there's just a little lateral medial fracture. You don't know anything about that injury until you've seen the patient. And that's a very different kettle of fish with that fracture underneath than if it was a closed injury. So whenever you see a fracture, think of the soft tissues, think of the damage that could have been done. When you've got a fracture which has got involves syndesmosis, don't forget, in order to disrupt that, the anterior inferior tibiofibular ligament, the posterior inferior tibiofibular ligament, the interosseous ligament, all of them have to be ruptured to allow the tibia and the fibula to separate at the ankle. And these Weber C, the high ankle fractures, it's a soft tissue injury more than anything else. I can put a plate on the bones, no problem, and fix it. But that patient will take a long time to get better because their soft tissues have been so heavily disrupted. So every fracture, think about the soft tissues, especially in crush injuries, lisfrancs, that sort of thing. Clavicle fracture, if it pokes a hole in the skin and get osteomyelitis and that fracture, it's a disaster. Fortunately, we don't have clavicles in the foot. What does everyone think of when they see this sort of foot? Charcot. No, it's not. Yeah, Charcot 2.
Yeah.
So, I mean, that's obviously one disorder, but I think this is neurological. Now, this could be Charcot 2, this could be spina bifida, this could be any of the lower motor neuron neurological disorders. So, when you see a foot like that, think neurology. So, you've got to think about, is it progressive? Is it static? Do I need to get this patient investigated? They could have what's called a diastylomyelia at the back, which means there's a bone block in the spine, and therefore if you can go and cut that bone block out, whatever nerves have been damaged will stop, but if you leave it, there'll be ongoing nerve damage. So when you see a foot like that, you've got to think neurology, which means you've got to think about soft tissues, muscle imbalance, and not just say, well, you know, the number of times I get a foot like that and they've got an arch support. And you think, what the hell's going on there? You know, why are you doing arch support with a foot like that? So always think the bigger picture with these cave-varus feet. Now, that one's quite obvious because it's pretty severe, but for the more subtle ones, where you don't have a known neurological disorder, or it's not progressive. Just a quick word on ankle replacement. As I said, it's only got about a 10-year lifespan. It's a very big operation in terms of, you know, you have to do a big exposure and cut the bones. And if it fails, the ankle fusion is difficult because they get short, and often you've got to put a big bone block in to maintain the length. I don't have one of these at the ankle. This is the only picture I've got of my patients. What is it? Say, I'm sure you're right.
Osteochondritis dissecans.
Correct, osteochondritis dissecans, which literally in Latin means to cut bone and cartilage. And as I said, I don't have an ankle picture of these, but you can see them in the ankle. If you're in a young kid, then usually the prognosis is very good, but otherwise you end up doing this sort of surgery where you can try and put the bit back, but it often doesn't work, and it's got a poor prognosis. What is this? What is it?
Fibroma?
Yeah, plantar fibroma. How should that be treated? Are you going to send that to me? No, never. No, never.
What if we're really desperate?
I don't care. No, I will not be operating on that. So plantar fibroma are benign conditions. Do you know if I did cut it out, which I never would, and send it off to pathologists, what would they say it looks like? Jupitrons. So it's the equivalent of Jupitrons in the foot. There are associations with Jupitrons. You get patients who say, oh, my auntie had this. So basically, they occur at any age really, and often they occur as a tender, painful lump that grows over a few months. It then stabilises and then it becomes painless, and sometimes the lump even goes away. If you inject them or operate them, they usually come back in a more aggressive form, 10 times as many. So you couldn't pay me enough money to operate on any of these or to inject them. If they're sore, I'll then refer them back to you guys and say that give them a donut relief around it until they become less tender, and then they'll have a pain-free lump. But I certainly will not operate on a plantar fibroma. And the key is that when you dorsiflex the great toe and tighten up the plantar fascia, you can feel the plantar fascia and they're associated with it, and the ultrasound will confirm the diagnosis, usually. And I'll almost always get an ultrasound just to make sure it's not a schwannoma or something weird. It's such an easy, cheap investigation. Usually you don't need MRI or anything complicated like that, and you just reassure the patient. Well, that's the end of the talks. I just want to say a few things. A question was raised about injectables. Now, the injectables that I'm probably talking about is PRP. And if people who don't know what that is, it's basically where you take blood and you inject part of that blood into somewhere. Usually it has to be spun off, and you might take the buffy coat, you might take the platelets, you might take, different parts. And this is the problem. Not all PRP is the same. So when you're reading in the literature about PRP injections, you need to know which brand of machine is used, because they take different parts off. Secondly, you need to understand that it's a big commitment for a patient to have blood taken off and then something re-injected, and it's going to cost $400. So there's got to be a big placebo-matic effect. And we did a level 1 study on non-insertional Achilles tendinosis. 5 or 6 surgeons got together with my radiology department. We sent all of our patients in. We were blinded, the patient was blinded. They went into a group where they either got all that blood taken off, then they either got local anaesthetic into the skin and saline and nothing, local into the skin and saline into the tendon, local into the skin and whole blood injected, or local into the skin and the spun down buffy coat injected. So 4 groups. Patient didn't know what they were getting, we didn't know what they were getting. They then went through their RIGIDUS rehab. We used repeat ultrasound and repeat visual A scores, and there was absolutely no difference amongst the groups. And that study's been repeated many times in the literature. There's a very big Scandinavian study in the Journal of Bone Joint Surgery. Similar results of tennis elbow, no help. The only studies that show PRP is of some benefit is a weak improvement in patients with early osteoarthritis, but it's probably no better than cortisone. So I'm not a PRP person. By the same token, I'm a surgeon, so I operate, but the sports medicine guys don't operate, so they might use PRP in a desperate patient. But the literature, it doesn't stand up to the literature. There is a material called Synvisc. Synvisc is chondroitin. It came on the market many years ago as 2 injections. It was $400, and it was said to replace lining cartilage. Now, it didn't really work that well. I tried it a few times and had a lot of success. It went off the market. It then came back on, and it's been remarketed not to regenerate cartilage, but to line the joint and lubricate the bone, which makes a little bit of sense. It's still $400 and it needs to be injected. Again, rheumatologists and sports med guys use it much more commonly than orthopedic surgeons. We operate, I guess. Some of the other things that people inject, what is it? Yeah, I don't know much about that, to be honest. So I can't really comment, but I suspect it's going to go by the wayside as well. The chondroitins and the other things. Did that answer your question? And it's tempting to do something when you've got a patient who can't be helped by anything else. But, I guess if it's their money off and they don't mind paying the $400 and having an injection and all that sort of stuff, as long as you warn them that, that's really hit and miss. Yeah.
Other than the jargon and so forth, what do you think would be the biggest mistake podiatrists or physios make in referrals to you or in their letters, and that kind of thing?
Podiatrists in Melbourne certainly are incredibly dogmatic. And there's a love-hate relationship between podiatrists and orthopaedic foot surgeons. Certainly it's been fueled by the operating foot surgeons and Brisbane had its problems. I think it's being very didactic and dogmatic and telling me, rather than being a little bit circumspect about it and suggesting, as I said, you've got to stroke the person's ego a little bit. And much in the same way as you wouldn't want me writing back and saying, look, you sent this patient with this, but you're really wrong. I don't know how you got it so wrong, you idiot. It's really this. I'm never going to write a letter like that because it's rude. So I think you just have to, as I said, we're smart guys and we see a lot and we've had really good training. And I'm not suggesting you're not smart and having good training either, but we all come from a whole different point of view. Just that language thing. We all come from a very different point of view. When I see a problem, I think of it a certain way. When you see it, you think of it in a different way. But just appreciate that. So just be a little bit gentle in the language. But certainly suggest, the diagnosis. But be wary then I understand what you mean by it. You know, you might say something and I think, what the hell is that? And my eyes will glaze over and I won't read the rest of the letter.
Is there anything that gets missed that you think podiatrists should be better at, or physio could be better at, that gets to you and you think that should have been picked up a lot earlier?
Oh, I mean, that's the same with everyone. I mean, plenty of my orthopaedic colleagues who miss stuff. You know, I probably miss stuff. So, not really. I mean, tib post is the big thing because that's such a common disease. And, you know, someone comes in, for instance, I had a guy came in and his problem was lateral pain and subfibular impingement. But when you asked him, 10 years ago, he had medial pain and that's when his foot collapsed. And then what happens is the tib post stretches and eventually becomes pain-free. The patient thinks they're better. But of course, all that's happened is the tib post is stretched beyond, there was medial structures are stretched. They then get either subtalar arthritis or subfibular impingement down the track and come in with lateral pain. And by then they've got an arthritic problem, you've got to fuse their subtalar joint. So if it had been picked up that it was tib post in the first place, when it became beyond control of conservative measures, you do an FTL transfer, you don't have to fuse their subtalar joint. So that's the classic one. Missed Achilles tendons, ruptures because the ultrasound says they're not ruptured. That's the other infuriating one where, you know, you speak to the physio and I say, I did a positive squeeze test, but the ultrasound said they weren't ruptured. You know, believe your clinical findings. You've got the patient in front of you, and that's the advantage that we've got as clinicians when we're looking at X-ray reports, ultrasound reports. We've got the patient in front of us, and MRI is the classic because it picks up so much. So when the MRI talks about anterior ankle impingement, but that's not their problem clinically. I mean, you've got problems because they're pain in the sinus tarsi. I couldn't care whether the MRI says they've got anterior ankle impingement. It doesn't hurt. So I ignore it because when in 2000, when the Olympics were on in Sydney, they put an MRI machine at the stadium and the MRI radiologist, who's a really talented guy, was there. And of course, no one hurt themselves, so they were bored. So they would just grab these runners off the track and say, come and have a free MRI, you know, from Nigeria or somewhere. So they found that, you know, especially say 5,000 metre runners, 10,000 metre runners who just competed or trained heavily, massive foot edema all throughout their foot, simply for the stress of running, you know, 10 Ks in 33 minutes, or whatever time it is. And so we've learned that MRI is so sensitive that, you know, you can do it one day and a week later it looks very different. So rely on your clinical acumen in taking the history, doing the examination, and read the MRI. I mean, you know, I try and learn to read MRIs. When you get a report, get the films up in front and see if you can correlate what the radiologist has said. I mean, they're right most of the time, but occasionally, you know, you've got to learn to read these investigations. Ultrasound is impossible, you can't read that, you just got to rely on the report. But, you know, learn to read the x-rays if you can, and that way you might be picking up the one that the radiologist missed because the report or the request didn't direct the radiologist to what the problem is. Whenever I write an imaging request, I write a paragraph. You know, I say, this patient has pain in the hind foot, it's worse with this, I suspect coalition of some, you know, subtalar joint. So you direct the radiologist to look at what they, because otherwise they've got a whole foot and with MRI 1,000 images. Now, any questions on anything? Foot and ankle, really, anything.
When you have a stage 4 like tib post issue and it's completely gone, but they're in no pain. I had one yesterday, and they say, like, I don't want to do anything, I'm in no pain here. I had a 72-year-old lady, and they want to walk out. Inevitably, they're going to have that lateral pain in that 10-year time, aren't they? Is that always going to happen?
First of all, how do you classify tib post? My classification, which is on myosin, so stage 1 is where they've got pain and swelling, but they can do a single leg U-raise and their arch hasn't dropped. Stage 2, they've got asymmetric collapse, but they're still mobile. Can't do a single leg U-raise. Stage 3 is where the subtalar joint is fixed in valgus, and stage 4 is where they've got ankle arthritis. So, how do you classify tib post?
Well, the stage 4 would be, you wouldn't be hard mobile.
No, stage 4 is ankle lane subtalar arthritis.
Yeah.
I mean, that's a rare.
You wouldn't be able to move it in stage 4, that's how it stiffens up.
Well, yeah. Well, stage 3 is the subtalar joint, but the ankle's normal.
Yeah.
So if you've got So a fixed subtalar joint, but normally it's arthritic and painful. By the time you get, I think what you're talking about is, so it's a grade 2, so the tip post doesn't work, but their hind foot's still mobile, and they're not in a lot of pain. And that's where you've just got to say, if you don't do anything now, later on down the track it's going to be a bigger operation. And it's a hard sell sometimes. And obviously, if they're in control, and this is where you guys come into it, because those patients are usually well controlled with orthosis and footwear modification. So while they're in control and you guys are looking after them, you know, I'm not going to assault someone with an operation. But I know that I say, don't let it go too far. If they start getting more collapse, because that will happen before they get the other things. If they get more collapse or it becomes rigid and fixed, get them on. Yeah.
Views on rupture with those kind of patients.
Sorry, what was that?
What are your views about rupturing or risk of rupturing with those kind of patients?
Well, the tip post rarely ruptures, it stretches. So even in ones that are totally degenerate and stretched and torn, and what we call torn, you go in and there's something there. Occasionally in a young to middle-aged patient you'll get a spontaneous rupture, and that's like that, you know, bingo. But the chronic tip post is a stretched degenerate thing that's big and thick, and you open it up and it looks like crab meat inside. And I mean, they don't rupture, they just keep stretching out, same with the spring ligament. Acute tip post rupture in a young person I repair, because it can heal, but that's rare.
Just back to the injectables,
Yeah.
do you do any dermal filler injections into the plantar fat pad?
I don't. Is that a cosmetic procedure?
Is that a
No.
trick question?
No, I don't.
Yeah.
I know nothing about it.
No, okay.
Does it work?
In the literature, but no one in Australia seems to know anything about it or do anything, and no one seems to know who would do it.
So is that for plantar fat pad atrophy in the heel?
Plantar fat pad atrophy in the heel or under the metatarsal heads.
Well, the metatarsal heads I see as a biomechanical problem, and so I'll fix the biomechanicals. Often it's a claw toe or a long second ray or something like that. So I'll try and fix it. Fat pad atrophy under the heel, impossible problem. And if you wanted me to try it and request, I'd do anything possible, because that's a really bad problem and there's no cure.
It's just on the Sunshine Coast, I guess. You know, of course, yes, orthotics great, wear shoes great, but people want to walk on the beach, people want to wear no shoes, and so just like, what is our other options?
Yeah. Fortunately, those patients don't come to me, because I certainly have no solution for that. That's a real problem. Usually it's, in my experience, it's usually been, you know, a 60-year-old farmer who's as tough as anything, and you go and you just feel this soft fat under the heel, and your heart sinks, and you know that you can't help them. I give them a little silicone heel insert, and that's about as far as I can go. I wish I had a solution. Unfortunately, I don't see many of them, because I just don't have a solution. Well, look, it's been a pleasure to talk. I'm sorry I've talked so much and spoiled all your dinners, but I would like to thank Michael from Regidus for sponsoring the event. He's done such an enormous amount of work to get us all here together. And Kelly, my secretary, who's come and helped as well. But thank you all most sincerely to come, because I do know how valuable people's evenings are. And hopefully you've got at least one pearl out of that. I find when I go to meetings, if I can pick up one pearl, I'm happy. So thanks very much, and don't hesitate to contact me at any time if you've got any questions or queries. Please fill out your evaluation forms, because otherwise I've got no idea whether or not I'm speaking a lot of rubbish or whether people are really getting something out. And hopefully you've got something out of the talk.
Just leave your evaluations on the table.